Okay, why don't I just get started since I know there's lots to do this morning. So I'm going to be talking about orbital anatomy for the neurosurgeon. So we rarely talk about orbital anatomy because we think it's a domain of the ophthalmologist, but I've seen a number of these cases with Dr. Morcos, Dr. Ivan, and Dr. Benjamin, and oftentimes I've seen these cases and found the anatomy to be somewhat confusing. So I thought it would be nice to review. And commonly we see these cases when we see anterior and middle skull-base tumors eroding into the orbit. So typically we see extraconal disease. And what that term actually means is that the disease is outside the cone of the muscle. So the extraocular muscles consist and make a cone, and inside of the muscles is considered intraconal disease and outside is extraconal. So common things that we have seen in terms of intraconal disease are optic nerve gliomas, optic nerve sheath meningiomas, cavernous hemangiomas, schwannomas, and then of course CC fistulas. Extraconal lesions that we've seen commonly here are meningiomas, of course, lots of infectious processes, so cellulitis that invade into the orbit, tumors such as squamous cell carcinomas, esthesios, lymphomas, even adenoid cystic carcinomas. So that's why you should care about the orbit, even though it's only 30 cc's, it packs a lot of different pathologies and has pretty complex anatomy. So I thought we would review the bones, the muscle, the motor nerves, sensory nerves, the vasculature, and then different approaches to the orbit. So the orbit is shaped like a cone, like an ice cream cone, where it's larger in the anterior portion than the posterior portion, and it's made up of 7 bones. There's frontal bone, zygomatic bone, maxillary bone, ethmoid, sphenoid, lacrimal, and palatine bone. Basically, every bone that contributes to forming the anterior middle cranial fossa attribute to the formation of the orbit's walls. So we'll start with the sphenoid bone. Can you guys see my arrow?
Yes.
Okay.
Yes, we can.
So the sphenoid bone makes up the center of the orbit, basically. You have the lesser wing of the sphenoid, which forms the posterior roof of the orbit, and then you have the greater wing of the sphenoid, which makes up the lateral orbit. And the space between them is the superior orbital fissure, which, as you guys know, transmits cranial nerves 3, 4, 6, as well as branches of V1, the lacrimal, frontal, nasal ciliary branches, and the superior ophthalmic vein. The optic canal is super important, of course, and is at the junction of the lesser wing of the sphenoid and the body of the sphenoid. And of course, that transmits the optic nerve and the ophthalmic artery. And so you can see the relationship here. This is the body of the sphenoid bone. And so posteriorly, medially, you have the sphenoid sinus, and then lateral to the greater wing of the sphenoid, you have the temporalis fossa, where the temporalis muscle is, and then posterolaterally, you have the infratemporal fossa. So then if you add on bones to the sphenoid bone, you can add on the ethmoid bone, which attaches anteriorly to the body of the sphenoid, and that makes up the additional medial wall of the orbit. So this is a thin bone called the lamina propria, which is part of the ethmoid bone. And then medial to that, you have these ethmoid air cells. And then medial to that, you see the middle turbinate. And that's how you can often access the orbit from a medial approach, endoscopic endonasally. It's also a common cause of orbital cellulitis. To add to the medial wall, you have the maxillary bone, which forms both the inferior wall as well as the medial wall. This is the frontal process of the maxillary bone, which contributes to the medial wall. And then finally, you have the lacrimal bone, which makes up the lacrimal fossa, which is not where the lacrimal gland sits, but actually where the lacrimal sac sits. And that's the sac that drains your tears into the nasolacrimal duct, into the nasal cavity. Also, you'll note some important foramina. So there's the anterior and posterior ethmoidal foramina, which transmits the anterior and posterior ethmoidal arteries and nerves. So that's your medial wall. You can use the acronym SMELL, which I thought was clever. the S stands for the sphenoid bone, M for the maxilla, E for ethmoid bone, and L for the lacrimal bone. And again, it contains a lot of the important anatomy. So there's the optic canal, the anterior and posterior ethmoidal foramina, the lacrimal fossa. This bone is the lamina propria, and then these are the suture lines between the bones. And as I mentioned, we commonly care about this because the lamina propria is one of the thinnest bones that make up the orbit. And so it's a common cause, it's the most common cause, ethmoiditis is the most common cause of orbital cellulitis. It's also frequently eroded by chronic inflammatory lesions, sinonasal tumors, neoplasms, and cysts. So if we add back to our sphenoid bone, if we add the frontal bone, that pretty much makes up the roof of the orbit. So the frontal bone plus, as I said, the lesser wing of the sphenoid make up the roof of the orbit. And then the zygomatic process of the frontal bone also contributes to the lateral wall of the orbit. So important things to note about the roof anterolaterally, essentially in the opposite side of the lacrimal sac is where the lacrimal gland sits. And then anteromedially, you have the trochlear fossa, which is where the trochlea is attached and where the superior oblique muscle runs through. And then the roof of the orbit can be thin and it can be fragile, and oftentimes it can be reabsorbed in old age. Now we get to the floor. So we talked about the maxillary bone and how it contributes to the medial wall. Well, the orbital surface of the maxillary bone also makes up the floor in addition to the orbital surface of the palatine bone. The floor is superior to the maxillary sinus, hence the maxillary bone. And posteriorly, it's separated from the lateral wall by the inferior orbital fissure, which transmits the infraorbital nerve, zygomatic nerve, as well as the infraorbital artery vein and the inferior ophthalmic vein. It has an important foramina, the infraorbital groove, which is where the infraorbital nerve travels through the infraorbital canal out through the infraorbital foramen to innervate the cheek and the lower eyelid. This is also important because it's also a very thin layer of bone, and it is commonly seen in blowout fractures. If you get punched in the eye, oftentimes the globe ends up into the maxillary sinus, which requires oculoplastics, ENT to repair that. And then finally, the lateral wall. So we talked about how the frontal bone contributes to the lateral wall in addition to the greater wing of the sphenoid. And the last piece more anteriorly is the zygomatic bone, the orbital surface of the zygomatic bone. So this is the thickest wall of the orbit. Posteriorly, it's separated from the roof by the supraorbital fissure. We talked about how the space between the lesser and greater wing of the sphenoid makes up that fissure. And it also contains important foramen, the lacrimal foramen, which is where the recurrent meningeal branch of the ophthalmic artery comes through, as well as the zygomatico-orbital foramen, which transmits the zygomatico-facial and zygomatico-temporal nerves, which supply the skin of the cheek and the temple. So now that we have a lay of just the land from just the bones, we can start to understand sort of this complex anatomy in relation to everything else, which is where I think neurosurgeons are usually involved in the orbit, is when you have extraorbital disease that invades into the orbit. So it's important to understand these relationships. So here you have the cone of the orbital apex, and then you see above anterior cranial fossa, medially ethmoid sinuses, sphenoid sinuses, maxillary sinuses inferiorly, and then you can note laterally you have the temporalis muscle and the temporal fossa, and the infratemporal fossa, and the middle fossa here has been removed. And again, medially ethmoid sinuses, sphenoid sinuses, and frontal sinus up here. And so now we can start to get into the orbit. Starting from above, this is obviously an easily recognizable view for us. You have the anterior fossa floor with the dura, and I think what's important to note is that there is a dural fold that extends over the optic nerve. This is called the falciform ligament, and it extends above the optic canal from the anterior clinoid to the tuberculum. You often need to cut this to decompress the optic nerve for large meningiomas or for ophthalmic artery aneurysms. Then if you follow that dura, that bilaminar intracranial dura actually splits and it becomes the optic nerve sheath and the periorbita. So the periorbita is actually continuous with the intracranial dura. And so this is what you see if you remove just the roof. And again, just to review, you have your frontal sinus, ethmoid sinus, sphenoid sinus, and then the cone of the orbit optic nerve. If you then remove or if you go a layer deeper, cut open the periorbita, you'll see three nerves on top, and that's the trochlear nerve, the nasolacrimal nerve, the frontal nerve, and the lacrimal nerve. And the reason that they're on top is because they are outside the annulus of Zinn. And here again, you can see the lacrimal nerve going to the lacrimal gland, the frontal nerve splitting into the supratrochlear and the supraorbital nerve, and sitting above this muscle, which is the levator palpebrae, and then the trochlear nerve, which goes across the optic nerve to the superior oblique muscle. And as I mentioned, you see these on top because they are sitting outside the annulus of Zinn. And I feel like the term, the annulus of Zinn, I always knew the term and I memorized what ran outside of it and what ran inside of it, but I actually for the longest time didn't know what it was. And it actually is the fibrous ring, the common origin of the 4 superior rectus muscles, and actually involves 6 out of the 7 main extraocular muscles. So you see superior rectus, medial lateral rectus, inferior rectus, the superior oblique muscle, and the levator palpebrae. Basically, the only muscle that's not involved in the annulus of Zinn is the inferior oblique. And so this ring encases the optic nerve and the optic canal, and then it splits the superior orbital fissure into the oculomotor side and the outside of the annulus of Zinn. And so here you can see annulus of Zinn, and the things that run outside are acronym LFT. So the lacrimal nerve that goes laterally, again, we saw to the lacrimal gland, the frontal nerve, which runs on top of the levator palpebrae, and the trochlear nerve, which runs atop and across the optic nerve to the superior oblique muscle. So this annulus of Zinn is important also when we later come back to talking about approaches to the orbit. One more view, if you look at it from a coronal view, you see this is the annulus of Zinn. You see the extraocular muscles starting from the top. You have the levator palpebrae, which sits on top of the superior rectus. Medially of the medial rectus, inferiorly inferior rectus, laterally the lateral rectus, and then inside you have the superior division of the third nerve, the inferior division of the third nerve, the sixth nerve, the ophthalmic artery, the optic nerve. And so one of the acronyms to remember the things that run inside the annulus of Zinn within the superior orbital fissure is 3N3 is 6. So you have 3 superior, 3 inferior, and a nasociliary, and then 6, the sixth nerve. And then you just sort of have to remember that optic nerve and ophthalmic artery are also there, but within the optic canal. And then outside you have LFTs, lacrimal nerve, frontal nerve, and the trochlear nerve, as well as your superior ophthalmic vein. And then quickly we'll go over extraocular muscles. I'm sure everybody knows these pretty well since med school. Superior rectus, which is innervated by the superior division of 3 and elevates the globe. Levator palpebrae, also controlled by the superior division of 3, which lifts the lid and also contains a smooth muscle portion called the superior tarsal muscle or the Mueller's muscle that is controlled by sympathetic nerves. Then you have medially, this is obviously the right orbit. Medially, you have the medial rectus, which adducts the eye and is innervated by the inferior division of the third nerve, which passes underneath the optic nerve. Then inferiorly, the inferior rectus, which depresses the globe and is innervated by the inferior division of 3. The inferior oblique, which starts at the maxillary bone and inserts laterally onto the globe. And then it elevates, adducts, and extorts or rotates the eye outwards. And it is innervated by the inferior division of 3. The trochlear nerve, which starts at the annulus of Zinn, goes through the trochlea, which we talked about was in the anteromedial roof of the orbit, and passes and attaches to the globe. And for some reason, I've always thought this is a little bit confusing how the trochlear nerve works, but it's important to recognize that it actually inserts from an anterior to posterior direction. And so when the main purpose of the superior oblique muscle is one, to intort the eye, and then also to depress the eye when the eye is already adducted. And that's because of that anterior posterior insertion of the eye. And then 6 innervates the lateral rectus, which abducts the globe. And then that's all the motor nerves. We can move on to the sensory nerves. You have divisions of V1 and V2. So you have the nasociliary branch, which comes through the superior orbital fissure from V1 and gives off the you have the frontal branch, which comes out through the superior orbital fissure and divides into the supraorbital and supratrochlear. The supraorbital is one that comes through the notch, or oftentimes is a foramen that we see when we do our typical frontal temporal craniotomies. And that supplies the supraorbital area above the eye. Then you have the lacrimal, which recites sensory to the lacrimal gland, the nasociliary, again, a division of V1, which gives off the anterior posterior ethmoidals, as well as short ciliary nerves that travel to the ciliary ganglion. And then they come out and innervate the face near the nose. And then finally you have, the branches from V2, which make up the infraorbital nerve, which travels through the infraorbital groove out the infraorbital foramen, again, to innervate the cheek, the zygomatic facial, zygomatic temporal, which travel through their respective foramen and innervate the zygomatic and temporal region. And then, of course, there are the additional parasympathetic and sympathetic nerves that travel through the orbit. And importantly, there's the ciliary ganglion, which sits along the optic nerve, and it receives parasympathetic supply from the Edinger-Westphal nucleus, and it sends its branches through the inferior division of the oculomotor nerve to synapse at the ciliary ganglion, and then they project through the short ciliary nerves to innervate the ciliary muscle, which contracts the lens and constricts the pupil via the pupillary sphincter muscle. The sympathetic roots, they originate from the carotid plexus. They do not synapse within the ciliary ganglion. They just travel with the short and long ciliary nerves to dilate the pupil. And those travel both with the nasociliary nerve as well as with the short ciliary nerves. And so here you can actually see, this is another Roten image, a ciliary ganglion receiving its both sensory and probably sympathetic supply from this, which is the nasociliary nerve, and then the inferior division of 3 here giving off its parasympathetic supply to the ciliary ganglion. And then, of course, the most important nerve of them all is the optic nerve, which is composed of retinal ganglion cells and glial cells. It is part of the CNS and not the peripheral nervous system. It's encased by the dura, the meninges, the pia, and its myelin is made up of oligodendrocytes, not Schwann cells. It has, you can think of it as having four components. There's the component within the globe, which is the optic head, which is only about 1 millimeter. And then there's the intraorbital portion, which is the longest segment, it's about 2.5 centimeters. The intracanalicular segment, which is within the optic canal, and the intracranial segment, which is about 1.5 centimeters once you get intracranially. And then there's partial decussation of the fibers, and about 53% of them cross over to form the optic tracts. And then, of course, we can't forget the vasculature. I'll come back and talk about this at the end. But the main things to note are that the ophthalmic artery comes off the ICA, travels inferolaterally to the nerve, and then usually crosses over the optic nerve and goes medially and supplies the muscles of the globe, of the orbit. It gives off, of course, the most important central retinal artery, which travels within the optic nerve. And again, here you can see the ophthalmic traveling inferolaterally to the optic nerve, crossing and going medially and giving off branches. The orbital veins are quite variable. So the main ones to remember are the superior ophthalmic vein and the inferior ophthalmic vein, which meet and drain into the cavernous sinus. Typically, your superior ophthalmic vein goes through the superior orbital fissure and the inferior goes through the inferior orbital fissure. It's also important to note that the superior ophthalmic vein usually courses from medial to lateral in the orbit, and the inferior ophthalmic vein courses lateral to medial. So now that we have sort of a lay of the land, we can talk about approaches. So several surgical approaches have been used to expose orbital lesions. And the main guiding principle when choosing which surgical corridor is to avoid working across the nerve, specifically the optic nerve. So orbital pathology that's lateral to the optic nerve is accessed via lateral orbitotomies, and medial pathology via medial orbitotomies. And traditionally, neurosurgeons have exposed the superior and lateral surface of the orbit using frontal temporal craniotomies or superior lateral orbital approaches, whereas the ophthalmologist likes to expose the orbit from extracranial or transorbital approaches, so from anteriorly, since that's just what we're both most comfortable with. So if you think of the orbit as like a clock, your frontal temporal craniotomy can get you from about 9 to 1 o'clock. If you add on lateral orbit, you can extend that to 10 o'clock. If you add on zygoma, it allows you to get a little bit more inferiorly to 6 o'clock. From anteriorly, the ophthalmologists typically do medial microorbitotomies, which we'll talk about, and then nowadays, more and more people approach the medial orbit via endoscopic endonasal, which gets you from 1 to 7 o'clock. So starting with the largest incision to the least, we'll talk about bicoronal approach historically has been used specifically for facial reconstructions and trauma cases, because it gets you access to everything, essentially. You can reach the entire cranial vault, anterior lateral skull base, you can reach the sinuses. If you release the supraorbital nerve from its notch or foramen, you can essentially pull the whole face down. You have access to pretty much the entire orbit except for the most inferior portion, as well as zygoma, zygomatic arch, TMJ. So we, rarely use that because it's hardly ever needed for intraorbital lesions, but it is a very useful incision for these large craniofacial reconstructions. Our workhorse is obviously the Tyrional Craniotomy. The term Tyrional was actually first termed by Hamby in this paper describing a frontotemporal craniotomy for orbital lesions. And so he basically described doing this small incision and then taking off the frontal bone, which allows you access into the roof of the orbit. And so here you can see the orbital. So you do your typical Tyrional Craniotomy, and your orbital exposure is obtained by removing the sphenoid wing to expose here the greater sphenoid wing to expose the superior orbital fissure, and then the frontal bone to expose the roof of the orbit. And here you can see the meningeal orbital band, which is basically a dural fold that connects the frontal and temporal dura and leads you to the superior orbital fissure. And you can expose even more of the orbital apex by doing a clinoidectomy. Here you can see the sphenoid ridge is being drilled down, your optic nerve, your superior orbital fissure, your clinoidectomy. It essentially unlocks the orbital apex. So super useful. And people have even described a contralateral Tyrional craniotomy to get you, so, you know, the normal Tyrional craniotomy gets you to the lateral, superlateral orbit. And people have described using a contralateral Tyrional to get you to the medial posterior edge of the contralateral orbit. Of course, that means significant retraction on the frontal lobes, potential damage to olfactory nerves, and is still a pretty limited exposure, but it is possible. So this is like a typical Tyrional case that you would use it for. I don't know why my video isn't playing. Oh no.
Do you have the video separate? Maybe you can play separate.
Is my screen sharing paused for some reason? It says it's paused. The video is playing.
It's playing.
You can see it?
Yeah, it's a bit choppy, but we can see it.
Sorry, yeah, I'm not sure why it's so choppy. So again, you can see drilling of the greater sphenoid wing, cutting of the meningeal orbital band. Here they're showing the optic nerve so that you can do a clinoidectomy and essentially completely unlock the orbital apex. And then they can take off the orbital roof, all from this Tyrional approach. You can get the meningioma, the intracranial meningioma, the dural attachment. And then once you're done with the intracranial portion, you can also reach all of the orbital portion of the tumor from just your classic Tyrional approach. So here you see them taking all of the involved periorbita off of the orbit. So this is super useful if, you know, all of the bone is hyperostotic and involved and you need to remove all of the roof and the lateral orbit. And you can see this is the final result. This is just a video from YouTube. I'm sure Dr. Marcos has significantly better videos. Compared with the Tyrional craniotomy, you can do an orbital-zygomatic approach, which gets you pretty much similar exposure to the orbit and orbital apex. If you take the zygoma, you can get slightly lower, but what it gives you is more anterior exposure to the orbit, more anterior superior if you take the orbital rim, and it also allows you to preserve the bone of the roof and the lateral orbit, which can be more efficient and less cosmetically deforming, depending on what the pathology is. The classic OZ, people talk about a one-piece or two-piece, can be done with 6 cuts, basically across zygomatic process. You're cutting the zygomatic bone at the lateral orbital rim, and then from the inferior orbital fissure to connect to that, as well as the frontal bone at the superior orbital rim, just lateral to the supraorbital notch, and then you connect the superior and inferior orbital fissure. More typically, to get to the orbit, really all you need is a modified OZ, or basically a cranial orbital approach, where you just take the roof of the orbit and essentially you make your cut just lateral to the zygomatic frontal suture, and then lateral to the supraorbital notch. and then you can cut across the roof of the orbit or fracture the roof of the orbit with a osteotome if you're doing a one piece. So this is an example where you can see previously when we did the Tyrional, you could expose this and drill the roof of the orbit, but now you have essentially this entire piece exposed and that bone is maintained, and you have this anterior edge of the orbit also available. Now again, progressively making smaller incisions, you can do a supraorbital craniotomy. This typically involves a eyebrow incision, and you can see from your eyebrow incision, this is the exposure that you can get. You can dissect the temporalis muscle down, put your keyhole, burr hole typically where it is, and then you can do a frontal craniotomy, and this gets you access to the anterior fossa floor. Here you can see opticocarotid cistern. So unlike the Tyrional crani, which is centered on the sylvian fissure and exposes temporal dura, you pretty much only get anterior fossa floor, which can be useful if you're doing just a anterior fossa tumor or anterior circulation aneurysms like an ACOM aneurysm. People often describe using this. The main limitation is that you really don't have great access to the orbital apex because you can't really see the superior orbital fissure from this approach, as well as there's just decreased surgical maneuverability in such a small hole. And people can have sort of a deforming scar along the eyebrow if it's not done correctly, and they can experience supraorbital numbness from damage to the supraorbital or supratrochlear nerves. From the same incision, though, you can also do a frontal orbital crani. So you can take the orbit. And again, you can do this through an eyebrow incision or even a transpalpebral incision. And that involves, similar to when you do sort of a two-piece cranial orbital approach, you essentially make your cuts lateral to the supraorbital notch, and then at the zygomatic go frontal suture. And you can see here with stepwise drilling how much more exposure you can get. So you can get the orbit, and then as you drill the lesser wing of the sphenoid, you take more of the roof of the orbit. You can see more lateral view of the chiasm, and then as you drill the greater wing of the sphenoid, you can see even more lateral view of the chiasm. You can also start to see M2 branches if you're looking at an MCA, and you get more exposure as you take more of the roof of the orbit. This is an example of a case where there was a anterior lateral cavernous hemangioma. An eyebrow incision was done, and the superior roof of the orbit was taken. Here again, you can see the keyhole is placed in the typical Tyrional region with the temporalis muscle dissected down. It's important not to cut the temporalis muscle here because that's how you get a frontalis nerve injury. So you have to dissect it off at the periosteum, and the orbital rim is cut. And here you can see exposure to the periorbita, the orbital roof, the frontal dura, with a nice result at the end. And so if you expose, all of these essentially expose the superior orbital, the superior orbit. And so once you get into the superior orbit, if you have a intraconal lesion, the question is, how do you get to the optic nerve? And so there's a number of corridors that Roten describes in a paper, and he talks about the medial corridor, which is often considered the safest. So essentially that means if you come back to the annulus of Zinn, coming in between the superior oblique muscle and the levator palpebrae. And you can see if you come through this corridor, you get directly to the optic nerve, and there's really no other nerves in the way except for the trochlear nerve, which crosses to the superior oblique muscle because that's outside the annulus of Zinn. So you can see here it's exposed, you can see optic nerve, and essentially all of the nerves go laterally, and you have a medial corridor to the optic nerve. There's a central corridor, which is considered the shortest route to the optic nerve. But again, you have to make sure that you protect the trochlear nerve, as well as there is the superior division of the ocular motor nerve, which runs under the superior rectus. So essentially the central corridor means splitting the levator palpebrae and the superior rectus. And there's also a ciliary nerve, which courses above the optic nerve. So those can all be in your way if you take a central approach. And then finally, there's a lateral corridor, which means coming in between the superior rectus and the lateral rectus. This can be a little bit complicated because as you can see from this diagram, a lot of the nerves run in the lateral region of the orbit, and so you have to retract all of them medially. In addition, the superior ophthalmic vein runs laterally, and so Roden talks about how there's two variations. You can essentially retract the ophthalmic vein medially as well, but that tends to get in your way, and so it's best to leave it laterally, and you have a better corridor to the optic nerve. So that's sort of the superior approach. If you want to take a more lateral approach, you can remove the zygomatic portion of bone. And here again, I wrote an image of what that would look like if you got into the orbit from a lateral region. You can lift the lateral rectus. You see the inferior rectus here with an inferior division of cranial nerve 3, and then you can reach your optic nerve that way. So the lateral orbital approach is useful for tumors in the lateral orbit, as well as you can get to the orbital apex. And Dr. Caldwell, last time when he was here, gave a talk about reaching the middle fossa and cavernous sinus via a lateral orbital approach. So basically, in this cadaveric example, they start with a lateral canthotomy. You can elevate the temporalis muscle off, and you have to do a lateral cantholysis. And then you dissect the periorbita off the orbital wall. You often can see the zygomatic facial and zygomatic temporal arteries here, and they can be taken if you need to. And then the orbitotomy cuts are made at the frontozygomatic suture, again, superiorly, and the body of the zygoma inferiorly. And then once that exposure is done, you can drill the wing of the sphenoid, and then here you can see all the way back. Here is cavernous sinus, here's V2, and all of the contents of the orbit are retracted medially. And this is the scar, essentially, that you're left with, just a lateral canthotomy incision. So you can do a combination of those. So basically, as we talked about, the lateral orbitotomy gets you access to the lateral orbit, as well as the cavernous sinus and the medial temporal lobe. It can go all the way pretty much up to the optic canal and Meckel's cave medially, but the supraorbital craniotomy gets you across to the anterior fossa, to the chiasm, to the supraclinoid ICA. And so if you combine those, if you do sort of an extended eyebrow incision and do both a superior and a lateral orbitotomy, you can get access to all of this from, a very small incision. And that, from a cadaveric study, looks something like this. You can see periorbita, frontal dura, temporal dura, and if you go down, that gives you access to the optic sheath, the supraclinoid ICA, and cavernous sinus. And if you take the anterior clinoid process, then again, you have access to the orbital apex. So that's superior laterally. What about medially? So the neurosurgical approach to the orbit is usually something endoscopic endonasal. And so here you can see you go trans-ethmoidal. So this is your typical view that we're accustomed to seeing over here, where you come transsphenoidal. You can see stella, clivus, and then more superiorly the planum, and then here's the ICA and the optic nerve, and this is your lateral OCR, which is a common landmark for knowing where you are when you do these endoscopic endonasal cases. So if you follow this out laterally and open the ethmoid sinus, then you get the lamina propria, and you can take the lamina propria, and that gets you to the medial orbit. And so what does that look like once you get into the orbit? You drill off the lamina propria, you're going to see periorbita, you'll incise the periorbita, and then you'll essentially see medial rectus and inferior rectus, and that's the corridor for getting into the optic nerve. Oftentimes, you'll also see the anterior and posterior ethmoidal arteries for the approach. I know this is typically an ENT approach, but those are the most important landmarks and sort of limit your exposure. They can be cauterized if they're involved in some skull-based tumor, but that's typically where the borders of your orbitotomy are going to be from within the nose. So this is a case that is from the American Academy of Ophthalmology. They talk about a patient with a medial cavernous hemangioma, and they do an endoscopic approach. Here you can see them incising the periorbita, the fat herniating out, and then the first thing that you'll see again is the medial rectus, and it's important to lift that medial rectus, and then you can see the cavernous hemangioma being identified and bluntly dissected and then removed. And it's important to protect all of the periorbita, and they do a nasal septal flap to close, because the periorbita and the fat is actually what allows all the muscles to move and to prevent scarring and a frozen globe. So that's the final result after the nasal septal flap is healed. And so that's the trans-ethmoidal approach. A transmaxillary approach can also be used from the contralateral nostril to get more of an inferior and a lateral view of the orbit from within the nose. Here you can see the plane of resectability. So you have your medial side through the ethmoids, and then the lateral side through a transmaxillary approach. And then really, again, the main principle of surgical approaches to the orbit is that you can't get anything that crosses the optic nerve. So you can see anything sort of superior and slightly lateral to the optic nerve can't be reached from an endoscopic endonasal approach. And before they did endoscopic endonasal, people did what's called a Caldwell-Luke approach, and this was primarily for, we talked about blowout fractures of the globe into the maxillary sinus. So there's an open approach, essentially a sublabial incision is made, and this is a case of repairing a blowout fracture, and a maxillary sinus piece of bone is taken from the front and actually used to recreate the floor of the orbit. So you can see this view through the microscope, and that's plated to reconstruct the floor of the orbit. And then we can talk about anterior orbital cranial approaches. So these are approaches that we rarely ever see because these are primarily done by oculoplastics, but I think they're pretty interesting. So there's a number of different incisions that can be done. We've talked about eyebrow incisions, transpalpebral incisions, canthotomy incisions. There's also a transcaruncular incision medially, subciliary incisions, transconjunctival incisions, so that they can all be sort of hidden. And the most common way that they do optic nerve fenestrations is through an anterior medial microorbitotomy. So that essentially gets you the medial 1 o'clock to 6 o'clock. Essentially, a medial conjunctival incision is done. Let's see if this video will play. So they can expose 270 degrees through a conjunctival incision, and then they cut the medial rectus, and they suture both sides and use the suture to retract the globe laterally. And then they also hook the superior rectus and the inferior rectus. Here they're just using a traction suture on the insertion of the medial rectus in order to pull it laterally. And then you can identify the long ciliary bundle, and then they can find the superior rectus and inferior rectus and hook it with a suture, and also use that to create traction on the globe. And then under the microscope, you can follow the globe backwards to identify the optic nerve. So again, you'll see lots of fat. They use Q-tips to dissect off the fat. Again, it's important to preserve all that periorbital fat to preserve the motion of the globe. And you'll see the short ciliary nerves around the optic nerve, and those will be lifted out of the way. And then there you see the optic nerve, and then it's just fenestrated with a blade, and typically a gush of CSF will come out for those patients who have pseudotumor. This is again another video from YouTube. You can also do a transconjunctival incision. So this is a incision that gets you to the inferior orbit below the inferior rectus. And the advantage, of course, is that they have no scarring. There's no bony work. But the problem when you're working just within the orbit like this is that it's very limited working space. And if you're dealing with something like a tumor, it can be very difficult to get enough space to work around it and not cause any damage to surrounding structures. But it's just one of the many anterior approaches. People have also talked about something called TONES, or transorbital neuroendoscopic surgery. This is an example here. It's basically a endoscopic approach through the orbit to get you to the intracranial compartment, including the anterior cranial fossa, middle cranial fossa, and the lateral cavernous sinus. So here you can see a lateral canthotomy incision being made. The lateral orbit is here. You see hyperostotic bone from a meningioma, which is drilled out. And you can see that they preserve the orbital rim all the way into the back. And then you can see temporalis muscle, and that gets you to cavernous sinus and the middle cranial fossa. And so again, to review, if you're looking at a clock, some of the useful approaches that we've talked about, transcranial really gets you superolaterally. All of this region with a zygoma, you can retract temporalis muscle even more, and you can get more of an inferior portion. TONES, which is the transorbital neuroendoscopic technique, can get you sort of lateral, and then medially you have your endoscopic and a nasal approach, either transsphenoidal or transethmoidal. And then the transmaxillary approach to get inferior, and then a medial microorbitotomy if you're coming anteriorly to get to the medial orbit. And I know I just have a few minutes left, so I wanted to quickly talk about some of the vasculature, which is also crucially important for neurosurgeons, primarily vascular neurosurgeons. So the origin of the ophthalmic artery has been classified by Matsumura as having 4 different possible origins, and there's a number of variations as well. But essentially, the ophthalmic artery can come off distal to the hello? Hello?
We're here.
I don't know. Are you still seeing my screen? It seems to be gone.
Yeah, it dropped.
Uh,
Try to put it back again.
Let me try again. Okay, are you seeing it?
Yes, we are.
Okay. So there's the distal origin, which is distal to the distal dural ring, and then the type B, which he describes as intradural, pretty much at the distal dural ring, which they found was the most common when they did cadaveric dissections. Type C, which is interdural between the proximal and distal dural ring, and then type D, which is intracavernous, meaning proximal to the proximal dural ring. This is obviously crucially important if you're looking at ophthalmic artery aneurysms and deciding whether or not to treat. If they are most commonly intradural, that's obviously a reason for treatment. But if they're located within the cavernous sinus or interdural, the likelihood of rupture is very low. And then the course of the ophthalmic artery is pretty interesting and important. So first it takes a small turn, which is angle A, and then it takes a larger turn, which is described as angle B. And then as we discussed, it travels inferolaterally to the optic nerve, then crosses over and goes medial to supply some of the extraocular muscles. It most commonly, like 80% of the time, crosses over the nerve, but sometimes it can also cross inferior to the nerve. And so you can actually see that on an angio. Here is a depiction where it comes under and over. And here on an AP, you can see it making that turn coming under and over from lateral to medial. And on a lateral, here you can imagine the optic nerve traveling like this to the globe, and the nerve and the artery coming under and then over and crossing over immediately. And of course, there are some crucially important branches of the ophthalmic artery, the main one being the central retinal artery, which goes to supply the retina. But then there's also a number of these ciliary arteries, which there are short ones and long ones, which supply the choroid, which is one of the highest vascularized parts of the body. You can see there's a lot of slack in these vessels, and that's because as the eye moves, they can still supply the eye. And so what you often see on an angiogram is the choroidal blush, and the choroid is essentially a layer deep to the retina and is highly, highly vascularized, and it's supplied 80% by the ciliary vessels. And the retina is supplied 80% by the ciliary vessels and only 20% by the central retinal artery. But so if you are concerned about a central retinal artery occlusion, which we often get called about, the choroidal blush itself is not indicative of whether or not just the central retinal artery is occluded. Obviously, if you have an ophthalmic artery occlusion, then you will not see a choroidal blush, but it's more than just the central retinal artery that contributes to this blush. The central retinal artery here, it's often very difficult to see on an angiogram, but you can see it comes off inferior and penetrates into the optic nerve and travels within the optic nerve. And very rarely you can see it's right here, and it comes off the curve of that ophthalmic artery before it crosses over. And so why is that important? Well, we think of ethmoidal fistulas as pretty much only surgical, and they're very risky to treat. But here's a case from neuroangio.org where they treated an ethmoidal fistula because they were, very cognizant of this anatomy. So if you see here's the turn of the ophthalmic artery, and it's feeding into this fistula. Here you see the dilated veins. And because that the central retinal artery and the ciliary vessels supplying the retina come off right around this turn, they decided that this was safe to treat as long as they could get their microcatheter out all the way to the distal ophthalmic artery, into these collateral branches through the ethmoidals. And so you can see they put their microcatheter all the way out there. They did glue, and they had a great result, and you can still see that choroidal blush at the end. The other thing to note are there are a lot of ophthalmic artery collaterals, so they can come from the MMA through the foramen of Hurtle. There's a meningeal lacrimal branch. It can come from ILT. You can get collateral branches from the anterior falcine artery through the ethmoidals that come backwards. You can also get collateral branches coming over the orbit from anterior deep temporal arteries and the facial and inferior orbital arteries. And why is that important? So for cases like chronic ICA occlusions or moya, what you often see is reconstitution of the ophthalmic and the ICA through collateral. So this is a case of an ICA occlusion here. You can see that's occluded. And you can see that these ethmoidals from the internal maxillary artery come back and actually reconstitute the ophthalmic artery here, which feeds back into the ICA and actually supplies the brain. And finally, you have the orbital veins, which I told you is very complex, but it's actually, I think, is one of the most difficult cases that we do endoscopically endovascularly are CC fistulas. So here you can see an angiogram, a venous angiogram of the superior ophthalmic vein going through supraorbital fissure, inferior ophthalmic vein, and they come back and meet at the cavernous sinus. You can see the ICA and the sixth nerve actually, and these drain into clival venous plexus, the inferior petrosal sinus. And if you're familiar with that anatomy, you can do a direct puncture for CC fistulas if you can't get access into the inferior petrosal sinus, or it's a indirect fistula and there's no transarterial routes. The direct puncture is actually a great tool, even though it can be rather terrifying. So this is a video from the group at NYU on JNIS, where they performed a CC fistula. Again, you have to be very familiar with your orbital anatomy, you know, your superior orbital fissure and inferior orbital fissure, and you sort of aim for the junction of them to get to the cavernous sinus. And essentially you aim anterior, you come from anterolaterally, feel along the floor of the orbit, and then you do it under fluoroscopic guidance. You see your cavernous sinus as a roadmap, and then you also have your bony anatomy, and you have to be seeing the superior and inferior orbital fissure clearly and aiming for that junction right there. And here you can see they did a Dyna-CT with the needle in, showing the needle in the proper place in the cavernous sinus. And then once you confirm your needle is in the correct place on angiogram and fluoroscopy, you can put your microcatheter and coil off the cavernous sinus. And they had a great result and were able to obliterate the fistula that way. And so I think that's my time. If you guys have any questions, I know that was like a lot to go through in a short amount of time. But I think that the marriage of ophthalmology and neurosurgery is necessary and can often have great results. So let me know if you have any questions.
Stephanie, that was terrific. What a spectacularly comprehensive review of the orbit. Really, congrats on putting all this together, even though your last slide is your best achievement to date.
Exactly. Thank you.
Really good. You went into, I'm sure the residents didn't know many of those details that you alluded to. Some of them you alluded to quickly, but fantastic. Congrats.
Thank you. All right.
You guys see my screen?
Yes.
Oh, okay, perfect. Thanks. So I'm Vignesh Kumar for those of you guys that don't know me. So this talk is about the material properties of patients. This is something I've been interested in for a while, going back to my research in undergrad in material science, although it was somewhat limited at that time. But I think it's very important because I think any innovation that's going to happen in this field in the future is going to hinge on a knowledge of what we used to do in the past in terms of spine instrumentation and what we're currently doing right now. So I'm going to gear some of this talk toward focusing on a little bit of the history and then some of it in terms of what we're doing right now and a little bit about what is going to go on in the future. The spine instrumentation really began to reach its genesis and its widespread use in the 1900s. And this is because prior to the 1900s, a lack of antiseptic technique, a lack of cautery, a lack of optimal anesthesia made actually non-surgical treatment of any unstable spine pathology favorable to operative treatment. And this sort of treatment mostly consisted of immobilization with either some combination of bracing, bed rest, or traction. In 1839, Jules Guerin, pictured here, was one of the first to treat spine deformity through surgery. And actually, in an attempt to treat scoliosis, he performed these percutaneous myotomies of the vertebral musculature and supplemented it with bracing. However, unfortunately for him, these surgeries weren't that great, and he had a very high revision rate. And after a lawsuit, was actually banned from practicing medicine and was exiled from France. In the 1890s, Adler was actually one of the first surgeons who was recorded to use spine instrumentation. And he took cervical fractures of patients with Pott's disease and wrapped silver wire and a figure of 8 fashioned around the spinous process of C6 and C7. This is just a illustrative figure. It's not actually, what he did. But so, that sort of goes to show the first sort of foray into spine instrumentation was actually this use of silver wire, which is a very inert material. Next was Mixter and Osgood, who used a new material, silk, which was wrapped around the C1 posterior arch and then around the C2 spinous process. And this 15-year-old patient that fell, and he developed this chronic non-healing odontoid fracture. And after internal fixation with the silk thread, the patient was kept in this rigid external brace for about 2 months after surgery. And in a publication 2 years after surgery, the patient was actually clinically stable and living an active life. So based on these two examples, as you can see, either by wiring or by suture, whether silver wire or silk, the primary method of internal fixation was with some sort of wiring. But this changed in the 1910s when bone, either from autologous or cadaveric sources, began to be used to promote fusion. And Albee and Hibbs, who I pictured here, developed methods to use autologous bone grafts for arthrodesis. What Hibbs did is he decorticated spinous processes, then folded them down to the level below, and then decorticated the articular surfaces as well to achieve these 3 points of fusion. And his later autopsies showed that his methods worked about 20% of the time, and then his patients generally achieved solid fusion. So you can see here the materials so far that have been used have been like silk and silver and now autologous bone. And along these lines, 1927, Forster used a vascularized fibular graft in cervical fusion. What he did is he maintained the vascular pedicle from the fibula and anastomosed it to the external carotid. And then the fibular graft was placed posteriorly to achieve posterolateral fusion. And so around this time, something interesting began to happen, and that was the production of American steel began to vastly increase, with about a growth rate of 7% year over year. And this increase was primarily due to the rapid expansion of infrastructure, right? Everything needed steel, whether it was office buildings, factories, railroads, bridges, cars, household appliances, everything needed steel. And the easy availability of iron ore and coal made supplying this demand very easily. And so with this, steel began to be used in spine instrumentation as well. On a logical next step to wiring and bone autograft placement, they were combined in an effort to maximize the advantages of both techniques. And in 1939, Gall used a combination of spinous process wiring and bone autograft between C1 and C2 for atlantoaxial fusion. And what distinguished Gall from previous surgeons is that he used steel wiring as opposed to other metals, including silver. And then 1943, and then 1 year later, in 1944, Kearney and King were the first to use screws for fixation. And like Galley's wires, these screws were composed of steel. These screws were pretty small. They were only 3/4 of an inch in women and 1 inch in men, and they were placed through the facet joint. And the goal of this was to eliminate the need for any sort of long-term bracing, any sort of long-term immobilization. However, patients were encouraged to stay in bed for about 3 weeks after surgery. And they reported a pseudoarthrosis rate of about 10% in the patients he fused from 5 to 1, L5 to S1, out of a total of about 40 plus patients or so. One patient, ended up developing nerve root irritation from a misplaced screw, so that screw ended up being removed. The idea of using steel in spine instrumentation stuck around for a long time. And Harrington developed this steel rod that was attached to hooks. And these hooks would be inserted either above or below the lamina. And the purpose of this was to treat spine deformity through some sort of combination of compression and distraction. And it could also be used in stabilization. I want to gear this talk more to the materials that were used in spine instrumentation as opposed to the different types of instrumentation themselves. But I just want to include this one point about Boucher's development of the pedicle screw in 1959 to illustrate one point about steel. And it was something that surgeons began to realize as they started to perform these multi-level fusions. Boucher's screws were longer. They were about 1.5 inches to 2 inches, and they went through the inferior facet, through the pedicle, and into the vertebral body. And he was one of the first to realize these longer screws that passed through the pedicle gave the construct much more strength, and it reduced the risk of pseudoarthrosis and the failure to fuse. And as you guys remember, until now, the major problem with spine fusion was either a failure to fuse or pseudoarthrosis, but the hardware itself wouldn't really fracture. And in his series, in 160 patients that underwent single level fusions, there were no case of hardware failure. However, in 14 patients that underwent multi-level fusions, he actually had 2 broken screws. And so this was the first time and really highlighted the need that, that surgeons could be limited by the materials themselves. And it sort of highlighted the need to identify stronger and more robust materials that could be used in spine instrumentation. And in 1970, Bailey and Badgley developed in 1960, Bailey and Badgley developed the anterior cervical fusion, but they did it without any sort of instrumentation. And in 1970, these two guys, Orozco and Lovett, were the first to develop the anterior cervical plate. But its use was really popularized by Casper in the 1980s. All of these systems were still made out of stainless steel, the plates and the screws, but the composition changed as they evolved. So the Orozco system and the Casper system initially just consisted of a simple plate with hole slots, but didn't have any locking devices. So what made it difficult was, in order to prevent screw back out, the surgeon either had to get bicortical screw purchase or angle these screws in such a way that they wouldn't back out, by strategically angling them. And ultimately, this difficulty results in the creation of this cervical locking plate, the CSLP, which is shown in image D there, which uses this small titanium pin that you can see on the side to actually secure the screw to the plate. And this allowed for unicortical screw purchase without resulting in back out. So this advance was very important because it was one of the first times that titanium was actually used in spine instrumentation. Obviously, there were many, many more iterations and revisions to the anterior plate, to the screws, to the locking mechanisms, to the trajectories, and even to the plate lordosis that have continued to persist today. And in 1970, there was another addition in terms of new materials to spine instrumentation, and that was with Roy Camille. They developed this plating system that could actually be used to overlie the pedicles and the lateral masses, and the screws would pass through the pedicles and the lateral masses. And he initially designed the plates out of stainless steel like everyone else did, but he also began to use what was a pretty new material at the time, Cobalt Chromium. And in the lumbar spine, he found that the average interpedicular distance was about 2.6 centimeters. So he placed these holes at 1.3 centimeters apart to allow placement of screws both through the pedicle and the facet. So again, despite the advent of all these new materials, the use of steel in spine instrumentation still persisted for a while. And the first construct that described screws that were directly connected to rods like this was by Dick in 1987. The screws themselves were 5 millimeters and the rods were 7 millimeters. And one important advancement of this system was that the screws could be connected to these lever arms, as seen in the first figure, and then that could be used to compress and distract the spine. So while titanium was used in plates and wiring and pins, it wasn't really used in screws until 1994. And due to the lack of titanium spine screws on the market, in the early 1990s, one group out of Toledo used screws designed for the repair of femur fractures in lumbar spine fusion, actually. And one of the most important benefits of titanium compared to stainless steel screws is that they had a much decreased artifact on CT scan and MRI imaging. And the outcomes were pretty similar compared to stainless steel at the time. 92% of patients achieved fusion. There was a 4% rate of pseudoarthrosis, and they didn't really see any broken screws when they used the titanium. So looking at sort of all spine biomaterials, there are 5 properties that sort of make the ideal spine biomaterial. 1 is being biologically inert and biologically compatible. 2 is having a Young's modulus, either similar to bone or surrounding structures, or having a Young's modulus that accomplishes stabilization and fixation of essentially what you need to do with spine instrumentation. 3 is fatigue resistance, 4 is a high tensile strength, and 5 is having low artifact imaging. So to point 1, all materials, whatever they are, range on the spectrum of bioreactivity. This ranges from biotolerant to bioinert, bioactive, biodegradable. So biotolerant materials are those that are accepted by the host, but they form this fibrous scar around them that separates them from the host tissue. And the way this happens is as chemical compounds and corrosion products are released from the implant, this reacts with host tissue, resulting in this formation of fibrous scar. Almost all synthetic polymers and most metals are biotolerant materials. Bioinert materials are those that don't generally react with body tissue. So one example is titanium. Titanium is an example of a bioinert material. Bioactive materials are those that actually actively interact with surrounding tissues. When bioactive materials are implanted, they stimulate a series of reactions that lead to chemical bonding. In the case of spine surgeries in the bone tissue microenvironment, bioactive materials are classified either as osteoconductive or osteoinductive materials. So osteoconductive materials are those that allow for bone growth along the surface of the bioactive material, and these includes things like ceramics, like hydroxyapatite, tricalcium. And osteoinductive materials are those that actually stimulate the growth of new bone. These include things like bioactive glass. And then biodegradable materials are those that degrade when they're actually in contact with body tissues. And the byproducts of these are excreted by the kidneys. And these include things like the ceramic calcium phosphate and magnesium, as well as bicryl stitches and monocryl stitches that we all know well. I just want to briefly touch about the Young's modulus. Greg talked about this last week in his talk, but it's known as the elastic modulus, and it's the measure of the flexibility of the material. And in essence, it's a measure of the stress to strain. So material with a higher Young's modulus is more resistant to stress for any given unit of strain that's applied. But I want to highlight this doesn't actually correspond to the material strength. A material that's a higher value here indicates greater elasticity, meaning it's less flexible, it's more stiff and more brittle, but it doesn't necessarily correspond to a stronger material. If you look at here, I included a graph of the Young's modulus, most commonly implanted materials. The values of cortical bone and cancellous bone are given on the left. And you'll see here that most metals, whether it's pure titanium or stainless steel or cobalt chromium, all have a pretty similar Young's modulus of about 50. PEEK has a pretty similar Young's modulus compared to cancellous bone, and carbon fiber reinforced PEEK has a similar Young's modulus to cortical bone. So, as I mentioned, whereas Young's modulus is a measurement of the flexibility of the material, it's expressed as a ratio. This concept, fatigue resistance or yield strength, is actually a measurement of the force of the strain that needs to be applied in order to cause permanent deformation to the object. So this is actually more of a measure of the actual strength of the material itself. So in essence, the yield strength is just the amount of stress that needs to be applied to a material. That a material needs to withstand before it no longer returns to its original dimensions, before the material is fractured. Tensile strength is just the resistance of the material to breaking when force applied along the longitudinal axis. And finally, low artifact on imaging. And MRI compatibility is a very important factor in any sort of post-operative evaluation. As you guys know, inability to obtain an MRI or a CT scan makes any sort of diagnostic evaluation incredibly difficult. So the most commonly used materials right now are stainless steel, which has generally been phased out, titanium, PEEK, and then the lesser used materials, cobalt chromium, nitinol, tantalum, and ceramic. Stainless steel was originally formulated in the 1800s, but actual makeup of stainless steel has been continuously revised, specifically with the purpose of achieving these different alloys that can serve these distinct specific roles to whatever it needs to fill. And because it's so customizable, It's grown to be used, it's grown to be used as one of the most widely used materials in all of civilization. The primary component of stainless steel is iron, and the stainless component actually comes from 11% chromium, which prevents against oxidation. It's actually mixed with many other elements as well, and the exact composition of it depends on whatever the purpose of stainless steel is. So stainless steel has many advantages and disadvantages. So it's strong, it's stiff, it can be alloyed into different compounds to make it stronger, and it's relatively inexpensive as well. However, the disadvantage of stainless steel is compared to some of the other metals out there, it's more susceptible to corrosion. It has relatively poor biocompatibility when compared to titanium. It creates artifact on imaging, and it is more likely to form biofilms compared to the other metals as well. Uses, again, it's primarily been phased out, but it can be used in rods, and it was previously used in screws, although these have been mostly replaced with titanium. Titanium was discovered in 1791, and like stainless steel, it can be easily mixed with many other compounds in order to create alloys. Most commonly, it's combined with iron, aluminum, vanadium, and molybdenum. So the biggest advantage of titanium is that it's not only strong, but it's also very lightweight. And so that's why it has many uses in the automotive and aerospace industry. In spine instrumentation, it either comes as pure titanium or as a titanium alloy Ti6Al4V, which is titanium mixed with 6% aluminum and 4% vanadium by weight. So the advantages and disadvantages of titanium: one, titanium is lightweight, it's strong, it's flexible, it's biocompatible, and it can be mixed into alloys to make it stronger. However, it's more expensive than stainless steel, and it also does create some artifact imaging. Titanium is pretty much used in everything: cages, rods, screws, plates, name it. And next, so PEEK stands for polyether ether ketone. It was originally formulated in the 1980s, and it's a plastic. It's a very, very robust plastic and resistant to chemical degradation, thermal degradation, biodegradation, and as such, it has a wide variety of industry applications, including ball bearing systems, piston parts, pumps, compressor valves, like insulation. And like all plastic, PEEK consists of a series of retaining subunits, which I include at the bottom here. And so the advantages of PEEK are it's lightweight, flexible, it's inexpensive, it's pretty easily biocompatible, and it can be alloyed and coated with different materials to augment its properties. It also has pretty low artifact on imaging. The disadvantages of PEEK: it has a pretty low Young's modulus, like I showed before, so it's pretty flexible, and there is some risk of graft rejection, but that has mostly been remedied today by coating and mixing. And the primary uses of PEEK right now are cages, rods, and disc replacement materials. So Cobalt Chromium was also formulated first in the early 1900s, and the mixture is a mixture of cobalt and chromium. And the material itself is very wear resistant, very resilient. It has a very high melting point. It performs well at high temperatures. It has good biocompatibility. It has high resistance to corrosion through this formation of a passive film of chromium oxide along its surface. Its mechanical properties are pretty similar to stainless steel. And as such, it's used anywhere where wear resistance is needed. So again, the aerospace industry, ball bearings, gas turbines. In the medical field, it's been used in prosthetic heart valves and artificial joints, these dental implants, like I showed at the bottom right. Its biocompatibility is driven, again, like I mentioned, that chromium oxide layer that forms on the surface. And it really doesn't have any problems with graft rejection mostly. And the advantages of cobalt chromium: it's very strong, it's flexible, it's biocompatible from that formation of the oxide layer, but it's more expensive than some of the other materials, and it also creates high artifact on imaging. And some of the uses, it's been used in rods in adolescent scoliosis correction. Next is nitinol. So nitinol is actually a nickel titanium alloy that's been composed of equal parts of nickel and titanium, but the exact formulation percentages can vary depending on what it's being used for. So as Greg mentioned, it was discovered in 1959 in the Naval Ordnance Laboratory, and it was actually discovered when they were attempting to find a metal that could be used in the nose of missile turrets to withstand heat and impact. Actually, it's a very interesting material. It has two properties. It has shape memory and pseudo elasticity, which are very different and can actually be harnessed in spine instrumentation for different properties. So the shape memory refers to nitinol's ability to be deformed at one temperature, stay deformed after the force is removed, and then recover its original shape when it's heated to its transformation temperature. Like I showed on the top left, that's just a paper clip that was deformed and then put in water and reformed. Pseudoelasticity refers to the ability for nitinol to undergo large deformation and then return to its original shape when the force is removed. And it can deform up to 10 to 30 times as much as other materials and still return to its original shape. And the key that separates these two properties of nitinol is temperature. So below the transformation temperature, it behaves with shape memory, and then above the transformation temperature, it behaves with pseudoelasticity and can return to its original shape. And because of all these mechanical properties and the elasticity, it's used in various damping systems in the industry and structural engineering, such as in bridges and in buildings. The advantages of nitinol is it's strong and it has the shape recovery ability, but it's more expensive. And as you can imagine, if it's flexible, the Young's modulus is kind of low for deformity correction. So it's not frequently used, but it's sometimes used in young patients with for scoliosis correction. Tantalum was originally discovered in 1802, and then since then has become a major part of electronics, and it it's called one of the technology sort of necessary materials for advancement of the future. It's an integral component of capacitors and resistors, and it's widely used as a minor component of many other alloys as well. It's highly inert, and chemical reactions that have needed to use platinum in the past have now been substituted with tantalum because tantalum is much less expensive than platinum. It's also very corrosion resistant, and the primary use of tantalum outside in the industry is in any sort of electronic devices, computers, phones, players. The advantages of tantalum, it's got a lower Young's modulus and high frictional characteristics, but it's more expensive, and it can't really be used in deformity correction because of the Young's modulus. It's not really frequently used due to its price, and it's primarily been phased out now with titanium. In ceramic, ceramic has has a history extending back almost 20,000 years, and it's been made by applying intense heat to clay and silica. It's very hard and it's brittle, but it's very heat resistant and it's corrosion resistant. And like stainless steel, it has a wide range of uses, including building material, turbine parts, disc brakes, missile nose cones, armor, electronics. And it originally started to be used in biological applications in 1969. And its the composition is pretty varied. It can be made up of aluminum, silicon, zirconium, carbon, but the ceramics that are used in spine implants are primarily composed of calcium phosphate, either hydroxyapatite or calcium triphosphate. The advantages of ceramic are that it's inexpensive, it's biocompatible, it doesn't lead to corrosion, it can easily be mixed into an alloy. However, it's very brittle, it has a very high Young's modulus with pretty poor strength, and there have been some issues with grafting of ceramics, but it's been improved with mixing and coating, and it's primarily used in cages now at this point. So I just want to briefly go over the 4 key components of spine instrumentation and sort of touch on how each of these materials are used in these different forms of spine instrumentation. So the first is interbody cages, screws, rods, and plates. So there are 3 main purposes of interbody cages. One is to stabilize force between vertebral bodies. 2 is to restore height of the intervertebral and the foraminal space. And 3 is to provide a graft for the vertebra to fuse and heal. The first interbody cages that were used with autologous bone grafts, and they were typically harvested in the iliac crest, as I showed here. There are various techniques that can be used for harvest, depending on how much of cortical or cancellous bone you need, and how much needs to be obtained and where it's being put in the spine. And one advantage of autologous bone interbody cages is that it generally results in good bony fusion because the graft is autologous bone. However, it's less frequently used today, especially from these iliac crest grafts, for many reasons. One is injury to the donor site. There's an extended healing time to the donor site. There's a high rate of graft collapse. There's an increased rate of resorption and substance compared to some of the other materials that are out there today. And out of all the metals that are available, titanium or titanium composite is the preferred metal because it is highly fracture resistant. It's biocompatible, it's corrosion resistant, and has a higher Young's modulus compared to bone or PEEK. However, the disadvantage of titanium, especially polished abraded titanium, is that it doesn't have very good bone bonding. However, this has been overcome by either coating the inner body or mixing it with some other material to help bone. The other commonly used inner body material is PEEK, and as PEEK, as I mentioned in the beginning, has a high Young's modulus compared to bone. And in ACDS, some studies have shown that PEEK has a lower rate of cage substance and less loss of Cobb angles compared to titanium because it's, quote unquote, more flexible and, softer than titanium. PEEK is also porous, and so it allows for bone growth, through the cage like a plastic. However, one disadvantage of PEEK is that it's a hydrophobic material, which makes it more difficult to bond with bone and achieve a solid fusion. There have been a couple studies recently that has shown a higher rate of pseudoarthrosis with PEEK cages compared to titanium cages. And this lack of bone bonding and a lack of achieving a solid fusion can ultimately lead to cage migration and pseudoarthrosis down the line. And then compared to titanium, the vertical compression strength of PEEK is lower than titanium, and it's actually 2.5 times weaker. If PEEK isn't coated with titanium or hydroxyapatite, it has these weak surface interfaces that can cause the cage to fracture on implantation, which is why some companies have started coating PEEK cages with titanium, as I include on the bottom here. There have been other materials that have also been used in interbody cages as well, although less frequently. And the two main avenues of research with these materials are either improving cage grafting or exploring biodegradability. There are several ceramic cages that are on the market now, and they're either composed of silicone nitrite or apatite wool austenite. And these ceramic cages have been shown to have similar rates of fusion compared to PEEK. Bioactive glass is another material that has been explored in the use of interbody cages, and its osteoinductive properties, like I mentioned before, making an attractive target for promoting fusion. And then finally, poly-E caprolactam is a biodegradable material that in animal models has shown pretty good integrity. Briefly touch on screws. Screws are used in pedicle fixation, and obviously in pedicle fixation, strength is absolutely key. And so because of the amount of strength that's required, almost all screws are composed of titanium, aluminum, vanadium alloy. However, these screws can be mixed or coated with other materials to supplement their strength or add certain properties, which is sort of the avenue that most research into screws are going. Hydroxyapatite improves resistance against pull-out force and has improved bone-to-implant contact. Other materials are calcium phosphate, which is osteogenic and pull-out strength. Extracellular matrix compounds integrate well with the bone microenvironment, and they promote screw integration well. Tantalum improves bone osteoclast proliferation in vitro in these in vitro models, and was shown to integrate well with trabecular bone when put in vivo models. And then finally, polymethyl methacrylate bone cement has greater pull-out strength compared to these other materials, but it makes screw revision harder at a later time point because everything is more solidified because of that structure. The purpose of rods next is stabilization, and rods have undergone significant evolution in structure and composition since the time of Harrington. So, French benders are used to design to contour rods. However, whenever you use anything to bend rods, the process of actually bending a rod imparts weakness onto the rod, and most cases of rod fatigue, fracture, and deformation usually occur either at these notch points or at the screw rod junction. And bending and notching rods actually reduces the stability of titanium rods more compared to stainless steel rods whenever you bend these rods. And so one solution to this has been to use these waved rods, which there's a lot of debate on these because they take away some stability. I include here on the right, they have these built-in sinks to actually absorb motion along the rod segment, which decreases fracture rate, but however, this all comes at the expense of stability and stiffness. So stainless steel rods were the first rod material that was designed. They have good stiffness, they have good stability for proper spine alignment, but they have significant artifact that is generated with imaging. They're also inexpensive. Stainless steel rods have largely been phased out now by titanium rods. So titanium rods compared to stainless steel has better biomechanical properties for bone. and it has improved biocompatibility and decreased stiffness that allow for stress shielding, especially in high stress areas like the lumbar spine. Titanium also doesn't have much artifact on imaging. Both pure titanium and titanium alloys are used kind of depending on what the purpose of the rod is. As I mentioned, cobalt chrome rods are stiffer than titanium. They're closer to stainless steel, and they're a good choice for adolescent idiopathic scoliosis. They're also corrosion resistant. So, and in studies that have used cobalt chromium rods for the correction of adolescent idiopathic scoliosis, they've been shown to have pretty good correction of coronal and sagittal realignment compared to titanium rods, especially in the thoracic spine. And that stable oxide layer prevents them from corroding. The primary drawback of cobalt chrome is that it's more expensive than titanium and it creates more artifact on MRI. The shape recovery properties of nitinol have been harnessed in scoliosis correction, and it can help augment scoliosis correction as well. And nitinol also has a very low rate of inflammatory response, and the oxidation byproducts that happen with nitinol don't trigger any sort of inflammatory response from lymph nodes or other organs. Again, the disadvantage of nitinol is that it's expensive, it retains the memory of defects that might be created in rod bending, and it has a lower Young's modulus compared to titanium stainless steel. Lastly, I want to talk briefly about PEEK rods. So unlike other rigid metal rods, PEEK is a semi-rigid rod. And so due to its flexibility, one advantage of PEEK is that, compared to titanium, is that it can be used in load sharing. That the flexibility of PEEK rods allow the stress to be distributed more evenly along the entire construct. However, because of the lower elasticity of PEEK, these rods have a higher failure rate, and they have a greater rate of reoperation compared to titanium and stainless steel, as shown in comparative studies. PEEK is also a radiolucent material, so compared to other metals, it only produces a very minor artifact on CT and MRI. However, because it's more radiolucent, it also makes it more difficult to identify any sort of rod fracture. So some PEEK rods have been mixed with a contrast agent to help improve visibility on imaging. And lastly, I just want to touch very briefly on biodegradable rods. Polycarbonate urethane is one form of this biodegradable rod, and the biomechanical testing with polycarbonate urethane has been shown to see how well it really retains its strength, which can help dictate its use. And so in these studies, through 3,000 loading cycles, they have a pretty similar Young's modulus compared to titanium. And they withstand about 5 million dynamic compression cycles under 145 Newton force before they break. But however, they decrease elasticity over time. And at 6 months, they have a 20% decrease in their Young's modulus, and at 80%, and at 12 months, they have an 80% decrease in their Young's modulus. So in the short term, they have pretty similar properties compared to the currently available materials, but this diminishes over the long term. So one thought is that these materials may be more attractive in single level fusions as opposed to these multi-level fusions when integrity of the rod is going to be needed for a longer period of time. And lastly, I just want to touch on, so plates are designed for stabilization, and the vast majority of plates are made out of titanium, either pure titanium or a titanium alloy. And like other forms of spine instrumentation, there's been an inroad into biodegradable materials, which has some advantages, some disadvantages. The PLA4G plate, which I showed on the right, is a biodegradable plate. It has a similar range of motion and torque strength and stress force as titanium, but the Young's modulus is about 60% lower compared to titanium. So in summary, spine instrumentation has come a long way, and from the early 1990s, these advances have come in biocompatibility and biomechanical properties. And two, with coating and alloys, we've done a pretty good job in ensuring that most of these implants are inert. And so that means that any research and any innovation that's going to happen in the future is going to have either with material or with technology, whether it's biodegradable materials or those with reduced imaging artifact, are going to ultimately hinge on two things. One is how well the material will ultimately lead to bony fusion, because that's ultimately the gold standard. And two, how well the biomechanics of the instrumentation that's available right now will help dictate fusion as well. And so, again, like any sort of innovation, any sort of research that's going to happen will always have to compete with what's available right now, either with titanium and stainless steel, and how well it achieves fusion currently. And so I can take any questions now. And then lastly, I just want to highlight the Neurosurgery podcast. We're coming up to almost 250,000 listens right now on the podcast. And thanks to all the faculty that have been on the podcast right now, Dr. Levy, Dr. Komatar, Dr. Morkos, Dr. Green, Dr. Jagged, Dr. Stark, Dr. Ragged. You guys made it all possible. It's by far the most listened to neurosurgery, most listened to podcast in the entire neurosurgery field available right now. If you guys haven't checked it out, be sure to check it out. We talk about things like this and many other interesting topics on the podcast. So, and at this point, I can take any questions.